The cardiovascular examination is straightforward and there is plenty of time. The difficulty is in picking up the signs, especially when the signs are subtle, the murmur is soft, or they are difficult to distinguish. We will now demonstrate the cardiovascular examination, paying particular attention to how you can optimize your technique to pick up signs that are not so easy.
Good morning, sir. I'm Dr. Koh. May I examine you today? Okay. Can you roll up your pants for me? Thank you. Can I have a look at your hands, please?
In the inspection step, you must pick up from the foot of the bed the presence of any prosthetic clicks, the presence of cyanosis, or the presence of any scars, such as a sternotomy scar, as well as the scar of an implanted cardiovascular device. Look at the legs also for whether there are any saphenous vein graft scars.
Can you turn your hands around for me? And relax your hands.
Time the radial pulse against your stopwatch. You must time for at least 10 to 15 seconds at a minimum to be able to identify any atrial fibrillation.
Any pain in your shoulders at all? Yeah, I'm going to lift your hand up, okay?
The collapsing pulse is an important technique and not often well done. The technique of the collapsing pulse is as follows. First, place the palms of your fingers on the radial pulse and palpate the radial pulse. Next, slide your fingers down such that the less sensitive parts of your finger, over here, lie directly above the radial pulse. And you know that this is the correct spot because you have previously palpated the radial pulse in this spot. With your other hand, support the elbow, but do not palpate the radial pulse. Support the elbow. Ensure that your right hand, in this case, is over and not under the radial pulse so that you will not change the strength of your grip. Put it over so that the strength of your grip is consistent. Supporting the hand with your left hand, in this case under the elbow. Ask the patient, sir, do you have any pain in your shoulder? I'm going to lift up your hand, sir, and lift the hand. It is not necessary to lift too quickly. What makes the pulse collapsing is a wider pulse pressure and the angle at which it is raised, or rather the height at which it is raised above the heart, and not the speed at which you raise it. If at this position you are unable to palpate the radial pulse, which you will be because you are using the less sensitive parts of your finger, and when you lift it up, the radial pulse becomes more prominent or is bounding, this is the presence of a collapsing pulse. If you identify a collapsing pulse, lower the hand slightly until you can no longer feel the bounding pulse. Now it is absent, I'm going to raise it again, and it becomes present again. This is a demonstration of a collapsing pulse. The collapsing pulse is a highly sensitive sign to identify the presence of aortic regurgitation, although the differential for it is a large and hemodynamically significant patent ductus arteriosus. It is important to identify the collapsing pulse, as sometimes the murmur is soft and not easy to hear unless you are expecting the murmur.
Okay. Can you remove your spectacles for me? And pull down on one of your eyelid. Thank you. And can you pull down your mask for me? I have a look in your mouth. And bring your tongue to the roof. Yeah. Perfect. Okay. Can you look to the left for me? Yeah. Look straight ahead for me. Okay. Next, I'll be feeling for your heart. Okay.
Palpate the pulse again in the carotid region, and be sure to distinguish this from the double waveform of the jugular venous pressure.
deep breath in for me. And out all the way. And hold it there. Okay, and deep breath in again. And out all the way. And hold it there. Okay, breathe away.
The common difficulty at this step is the inability to identify a murmur, especially those that are softer, or the inability to distinguish murmurs from each other. There are a number of strategies that are important here in the technique. First, ensure that you auscultate over the right spot. Ensure that you're auscultating directly over the apex beat in the case of the mitral region, for example. Time the murmur against the carotid pulse. Take your time. There is plenty of time in the cardiovascular examination. As you auscultate, inch your stethoscope around slightly. This may improve your pickup of some of the softer murmurs. Listen in both inspiration and expiration, remembering that right-sided murmurs are louder in inspiration and left-sided murmurs are louder in expiration. Pay attention to the individual components of the cardiac cycle in turn. Listen first to the first and second heart sound. The presence of a loud first heart sound at the mitral position, for example, may be the first clue and the most obvious sign that the patient has a mitral stenosis. Sometimes you will find that there are many sounds in the cardiac cycle, and when you have this situation, what you want to do is to listen to individual components of the cardiac cycle in turn, timing it against the carotid pulse. So first you listen to S1, S2. Is S1 alright? Is S2 normal? And you listen to the systole. Is there a systolic murmur? If so, what is the timing of this murmur? Where is this murmur loudest? Is it louder in inspiration or expiration? And then listen to diastole, whether there's any additional murmurs in diastole. It is not uncommon to miss a second murmur when there is a radial first murmur. So for instance, a mixed mitral valve disease, where you have both a systolic and a diastolic murmur. So do not stop when you hear the first murmur, but always ask yourself, is there a second murmur?
Could I get you to roll to the left?
Again, for this step, ensure that you palpate for the apex beat again before you auscultate to optimize your pickup.
Deep breath in for me and out all the way and hold it there. Okay, breathe away. Can I get you to sit up for me?
If you have not identified any abnormalities in the cardiovascular examination, this maneuver, when you roll the patient to the left, is your chance to auscultate again for soft mitral stenosis.
Okay, deep breath in for me and out all the way and hold it there. Okay, breathe away. Deep breath in for me and out all the way and hold it there. And breathe away.
The murmur of aortic regurgitation is often heard not just at the lower left sternal edge, but in a band from lower left sternal edge to the aortic position, which is the regurgitant jet of the murmur. In certain cases, if you do suspect an aortic regurgitation, but you are unable to auscultate it at the lower left sternal edge, you may wish to inch the stethoscope upwards towards the aortic region, and you may hear the murmur over there.
Using your mouth, just some deep breaths in and out for me. Okay. You can lie back down. Any pain in your legs at all?
We have not demonstrated the radial femoral delay in this video, and if you wish, you may do it at the end. It is also helpful to request for a blood pressure from the examiner, as this will help you to identify the presence of a narrow or wide pulse pressure. This is the cardiovascular examination.